Thank you so much, and we will certainly come back when we have the discussion round to you. Thank you. The next speaker is not there, so then we go to the second Israeli speaker listed in this session, but you are now the first. Welcome. And we are switching, I think, gears to chemotherapy, arterial chemotherapy. And this is Professor Elnekave, and you're from Jerusalem, I think. I have to see. Oh yeah, that was striking. You have a company, Listen Therapeutics. So I'm very curious what Listen, where it comes from. Maybe you could incorporate that in your lecture, but it's just a gentle question. And for the rest, you are from the center of the hospital, the medical center. I always have difficulties in pronouncing the name. So Shah Sedek Hospital. Welcome. Please take the floor.
Thank you. We will stick to being optimistic, although I'm going to spend the next minute also being realistic. A lot of my colleagues are not here because of a less realistic reality. I have a problem with this. Do we have a pointer? This is a video. Okay, I'm going to invite you to think a little bit differently about some of the topics we've been thinking about. We've heard a lot about neoadjuvant therapy and the concept of systemic therapy versus surgery. Do we need surgery? Can we give systemic therapy to maybe avoid surgery or improve the outcomes of surgery? And what I'm going to talk about today is not systemic versus local, but rather local systemic. How do we leverage the armamentarium that we have of systemic therapies and use the natural conduits in the body to deliver them in a local way? So we have, every tumor has an address, and that address is an arterial address. Not only does it have a regional geographic address, but it creates its own blood supply, as we know, that gives us what we're familiar with in terms of enhanced permeability and retention. And I'll show you what that looks like. So this is a picture of a tree, and this is the arterial tree in the liver of a tumor, and we can see where the tumor is because we can see the EPR effect here, what we call an angiographic blush. Okay, now if we can navigate catheters into the arterial vasculature, and this is very commonly done in the liver, known as TACE, transarterial chemoembolization, we can get to the tumor's front door, and we can treat the tumor selectively. So this has been really widely used in the liver, but today we're going to talk about outside the liver. Okay, so And I'm going to talk about microbeads. In the world that I generally live in, when I say 100 microns, people say that's very, very small. I know here it's enormous. But these are 100 micron beads that are polyvinyl alcohol beads that are coated in sulfate. And here we take advantage of the protonated amine group that exists on doxorubicin to do an ion exchange, or compete. And we basically drop these particles into doxorubicin, and then naturally the doxorubicin adheres to the particles. Now the advantage with that is that it gives someone like me the ability to navigate into the tumor vessels and deliver a very high dose of doxorubicin into the tumor, outside the liver, in the liver, while avoiding the systemic toxicity. So this is, again, local systemic treatment. And here, I think I was in Cleveland about 5 years ago with some preliminary data. Here we have more of a follow-up. So here we have a patient with a large sarcomatous. It's a desmoid fibromatosis tumor in the axilla. And the doses of chemotherapy required for this would be too much for, she's 6 years old, she was then. But you can see here that the vasculature to this tumor is very prominent. We can see the chest wall, and we can see the brachial artery and so forth. We can navigate selectively into the tumor and deliver high doses or local doses of doxorubicin here. So over the course of 4 treatments and 1 year, we have this result, which was 97% reduction in volume. This is not a tumor that will metastasize, and if we can control it locally, that's enough. And what you can see on the skin is actually the color of the doxorubicin. Another example, so this is was 16 then, with an expansile desmoid fibroma in the forearm, underwent multiple lines of chemotherapy, cryotherapy, surgery, and the tumor feeding supply here is the interosseous artery between the ulna and the radius. You can see the blush here. You can verify that nothing is going to the hand, and after 2 treatments, 9 months later, this is what it looks like, and it's stable since. So we described these preliminary results in 2018 on 4 patients. And then we kind of opened this up to other centers. So I had come from Memorial in New York. So we had Memorial Sloan Kettering, LMU, we had a Hong Kong group, a Sydney group. And I'll give a little bit of data on our results there. We started to treat beyond extremities and beyond children. So what we see here is a large, really a massive tumor involving most of the mesenteric space of a 51-year-old. And what you'll see here is getting into the superior mesenteric artery. So this is the the vasculature supplying all of the small bowel and a part of the colon. And if we look for it, we can find the tumor supply. So again, we see this blush from this single parasitized branch of this mesenteric artery. And before we treat from this position, we want to do the following. So you'll see on the left, the diagnostic CT. This is an axial slice. So you're looking kind of from the feet up. In the middle, we have an injection from the superior mesenteric artery, and we can see the white contrast that is in the tumor and also in the bowel above and below the tumor. This is the level of the pelvis. And finally, where we have a super selective catheterization, we're injecting contrast. And at this point, we can be safe and confident that if we direct treatment here, we're not going to cause either ischemia or any other chemical toxic effect to the bowel, but we're locally targeting the tumor. And this is what it looks like 10 months later after 2 treatments. So this is a T2 sequence in coronals. This is the way we look at the world normally, head above, feet below. And we see the reduction in size, but also importantly, what we call the T2 intensity, the brightness of the tumor on this particular sequence of MRI. And a similar findings. So these are the results that we published in the end of 2022. I'll go through a bit of the data. So we had 24 patients, and this tumor is about 2-to-1 female-male, as it was in this case as well. About 2/3 of the tumors were either in the abdominal or chest wall, or in the neck, shoulder, axilla. We had 1 mesenteric tumor, and we had 3 mesenteric tumors and 1 mediastinal tumor. Most of these patients had had surgery or chemotherapy before. but about a quarter of them, 7 of them, this was first-line therapy for them. And the median time from diagnosis to this type of treatment was 2.5 years. The total doxorubicin dose delivered per patient, the median was 75 milligrams. Based on some of the pharmacokinetics that we have, that 75 milligrams gives about 7 milligrams at most systemic exposure. So I'll give you a bit about our results and say that we had, so this was a study that had an accelerated accrual of patients, which was somewhat problematic because we have a lot of patients with a shorter term follow-up, and then we have about half the patients with a larger term follow-up. But if we look at those with more than a year of follow-up, we have an overall mean reduction in tumor volume of 76%. Those with a year or less have 44% reduction in volume, and there are similar results in terms of T2 signal. Clinically, there's a significant improvement. Patients with desmoid tumors in particular, once the tumor stops growing, or they feel that once it stops growing, they feel there's less pain, and where there are functional symptoms, they tend to improve. Okay, so this is just a waterfall plot based on RECIST criteria, and importantly, RECIST is not really relevant for a tumor that's not going to metastasize and kill the patient. This is what the volume looks like. Again, we see more significant volume changes with longer follow-up. In terms of safety, this is important. So we had one patient with a grade 3/4 complication, a neurovascular injury during catheterization, and that was our only grade 3/4 complication. This is the gist of it. If we let's just say another study that was similar study performed by the group at Memorial Sloan Kettering. This is kind of a very quick study, 11 patients, very short-term follow-up, but showing very similar results to what we've documented here. And that's kind of looking back. So a summary is that for soft tissue, specifically for desmoid tumors, over the past few years, we've had some significant breakthroughs. Some of them have been systemic. So from 2018, 2019, we have a Lancet Oncology and New England Journal kind of introduction of tyrosine kinase inhibitors, sorafenib, pazopanib, that have overall some good efficacy. But again, these are drugs that have more significant systemic toxicity. So you're using a systemic drug for a local disease, which is what we do almost always. And I welcome you to consider how can we combine a local approach and systemic therapy. And this is one example. In this case here, in summary, we have 2.3 treatments on average using embolization of doxorubicin versus a daily treatment and sometimes really indefinite continuation of systemic therapy for this disease. So the way forward, we're now doing a kind of a phase 2 multi-center prospective trial under the EORTC to establish this in the place of the treatment algorithm for desmoid fibromatosis. But I was asked to at least introduce the concept of LISTEN. So far, we've looked at the arterial front door of a tumor, and we've talked about the use of one drug to treat this particular tumor, which is desmoid. But we've already treated other types of sarcomas with similar results. We haven't published them. But now I'd like to think about what are the options of understanding in real time what is the right therapy for any particular tumor. If you can catheterize the arterial tree and you can deliver a combination of drugs, and we want to find out what is the appropriate drug for this patient, one way to do it is to listen to the tumor. The tumor is speaking. We sort of are yelling at the front door, and we don't listen to it. But if you catheterize the venous side of the tumor and you assess the response, within 30 minutes you can assess what kind of drug is having what kind of effect. And this is an approach that can bridge a theranostics or a diagnostic approach and a therapeutic approach to actually figure out what works and treat to completion. That's the concept behind LISTEN. Thanks for your attention.
Thank you so much. just before the start of this session, we met, and also the next speaker, Professor Gabrielson, and we discussed, of course, this barbarian attack on Israel. And I was wondering, why are you here? Why can you be here? And you said to, and at least for Alberto, you were outside Israel before the start of the war. And Alberta was on vacation in Interlaken. So I just want to express that we all condole. We are with our thoughts with Israel in this very terrible situation. And we hope for the better soon. And wish you strength, both of you, in these circumstances.